Welcome. My name is John Mitchell. I'm going to be your chair for the next 1 hour and 20 minutes. We're running 10 minutes late. It's a bit like being on the last flight to Geneva. There's always a couple of planes beforehand that are late. And so we're going to finish at 4:30. So we've got 1 hour and 20 minutes. So, welcome to this session, which has been called It Doesn't Work, Gaps in the Humanitarian System. I think we should pause for breath just for a second, right at the beginning there, and remind ourselves that there are some things, I think, in the humanitarian system that are working up to a point. And you know, the Humanitarian State of the System report, which I'm sure you've all read, describes a system of sorts. We heard Eve earlier this morning talk about whether we can actually call this thing a system. But there is a system of sorts out there that reaches many, many people in very large numbers of people in very difficult circumstances. And I think the report shows that it's also a system that seems to be improving incrementally and very slowly. But having said that, we also know that our delivery mechanisms are very uneven, they're disproportionate, they're fragmented, and of course, as Eve was saying earlier today, they're politicized. And this means there are structural gaps in the system. There are winners, people that win, and there are losers. And the aim of this session is to examine some of the losers in this, and some of the important gaps in the current arrangements. And to do that, we're going to call on three very experienced panelists who between them are going to cover three areas. Coverage and inclusivity, that's the first one. Coordination and coherence is the second one. And the third one is organizational culture and practice. And I'll explain what I mean by that in a minute. But before I do, I'd like to introduce you to the panelists themselves. They're all very experienced people. They're all very deep-thinking people, and so we're very lucky to have them. So we have Corinna, oh dear, I'm going to get this wrong, Kreidler, and she's the Deputy Director of the International Programme Department of Norwegian Refugee Council in Oslo. She's got a master's degree in political science from the University of Freiburg and has worked for 18 years in humanitarian aid for NGOs and as a donor representative. And her previous stations have included Mozambique, Angola, Liberia, Sudan, and Democratic Republic of Congo. And at the other end of the table, we have Frances Stephenson, and she's been working in the humanitarian sector for over 20 years with MSF and other international NGOs. She was the coordinator of the Humanitarian Practice Network at the ODI for 4 years, and she's worked as an independent consultant on humanitarian policy and practice. And since 2009, she's had the pleasure of being head of emergencies at HelpAge International. And in the middle are our token man on the panel today. I joke, Sean. Sean Healy. He is humanitarian advisor for MSF UK, based in Melbourne, Australia. Is that correct? So you how do maybe you can tell us how we were all asleep when you were working. How does that work? Anyway, you were originally a journalist and with an academic background in international political economy, and you joined MSF in 2002 as a press officer working in Sydney, and then for MSF's campaign for access to essential medicines in Geneva. Sean's also worked in Burundi, Kashmir, Baluchistan, the Tibetan Autonomous Region of China, and since 2011, he's worked as humanitarian advisor for MSF, conducting research in conflict situations. Good. So before we get going, let me just get back to what I was saying earlier and provide a little bit more background and context about the three areas I mentioned earlier. So if you remember, the first one I said was coverage and inclusivity. And here we're looking at who are the hardest groups to reach and why does the humanitarian system continually fail to deliver a proportional response. And so here we're going to look specifically at agency experience in reaching elderly people and those populations living in inaccessible areas. And so particularly Francis and Sean will share their experiences and reflections there. And the second area is on coordination and coherence. And you all know that the humanitarian reform process is taking place, and the cluster system has been designed as part of that to bring actors together to achieve a better overall response and to really engender a more harmonized approach under strong leadership. That's the idea. But are these efforts in practice inadvertently bringing about further fragmentation of the system? That's the question. And Corinna was going to shed some light upon this interesting and developing area of humanitarian action. So that's the second one, coordination and coherence. Third one is organizational culture and practice. Here we're asking, are individual agency strategies and ways of working getting better? Are the actual elements, the components, parts of the humanitarian system getting better, or are we as agencies getting a bit too used to blaming the system for our shortcomings? So underlying that question is, are our current response systems fit for purpose, and is the right leadership in place? And Sean is going to focus on this, and I think Corinna's also going to touch on it. So we're going to try and make this as interactive as possible. Our panelists are really concise in their thinking, so they're not going to speak for very long, but what they're going to say is going to be incredibly concise, lucid, and important, and riveting and engaging, I hope. And then we'll have a discussion. We'll bring you all in. There's lots of good issues that I think are going to come out of this. And so, as I say, we'll finish in about an hour and 10 minutes. Great. So, first up is Sean.
You're the chair, John. You set the order, didn't you? I'm first, aren't I?
Yeah,
okay.
I'm an old man. I've got a very bad memory.
Okay. Thank you, everybody. Thank you for the opportunity to speak. MSF over the last few years, in particular since the Haiti earthquake in 2010, has been very critical of what it perceives to be failings in the way that the humanitarian system responds, particularly in emergencies. Comments by our general directors, by our international presidents in Somalia, in Pakistan, in the floods in 2010, during the Haiti cholera epidemic in particular, and other places, have been pointing towards systemic failings or perceived systemic failings and major gaps. My colleague Sandrine Tiller and I, Sandrine is presently in Istanbul presenting the same version of this presentation there. Be interesting to see whether the responses are similar or different. Have spent the last year or so working on 3 case studies to try to test whether those criticisms are generalisable or whether those are really coming out of the worst case scenarios that have happened. So we looked at 3 cases, principally displacement crises, so I think that's really the focus of our work, in Maban County in South Sudan. So this is where a population of about 150,000 refugees fled conflict and violence in Sudan, crossed the border and assembled in eventually four refugee camps in Maban. Then North Kivu, since the mutiny and the formation of the M23 rebel group and the realignment and rise of massive violence in North Kivu since April 2010, including the prise de Goma, the taking of the capital city of the province Goma by the M23, and the doubling of displacement in the province to about 900,000. And then thirdly, the flight of Syrian refugees into Jordan. There are presently approximately 700,000 Syrian refugees in Jordan, most of whom have come in the last year. So we looked at these 3 cases, and what did we find? Firstly, it should be said on the positive side, it is clear that the humanitarian system can mount very large-scale and relevant operations which are life-saving in emergencies and in displacement crises. It is very difficult to measure impact of humanitarian operations and in particular mortality data. To see trends in mortality is often very difficult. Of the 3 cases that we looked at, really the only case where we have very good data is Maban, because it was a closed setting, that is everyone was in camps, and we can actually see the mortality curves. But nevertheless, it does appear that humanitarian assistance in all three of those crises was capable of saving considerable numbers of lives. The question is whose lives, when and how is more the interesting point. In all three, I think we found, I'm going to move on to coverage in a second, but in all three we found significant difficulties in effectiveness and reactivity. On the last point, in general, it seemed to have taken in all three of the crises, it seems to have taken about 3 to 4 months before the humanitarian system was really able to stabilise conditions for refugee populations in each of those places, and that's actually in its best case. In some cases there were populations which weren't reached till much later than that. And also we found repeated difficulties in things that in some ways we think should be more or less par for the course. Repeated site planning failings in refugee camps, for example, repeated failings of contingency plans, repeated technical difficulties, particularly in Watsan, in Maban in particular, was very, very difficult. So in reactivity and effectiveness, certainly major issues, but the major problem was really in coverage and in getting beyond certain core populations. In North Kivu and in Jordan, there was very, very heavy lean towards assistance focusing on camp populations and not getting to any of the populations outside of the camps. In both of these settings, approximately 70% of the refugee loads are outside of the camps. In Jordan, they're principally now in the cities in the north, where, of course, they put a massive strain on Jordanian public services, including health. In North Kivu, 70% of displaced people are with famille d'accueil, host communities, I guess you'd say. And further, it should be pointed out in the North Kivu case, of the remaining 30%, half of those, so 15%, are in officially recognised camps, and the other half are in more informal or spontaneous camps who also get significantly less assistance than those who are in official camps. Further, there was a very heavy concentration towards geographic concentration, particularly noticeable in North Kivu, towards the easiest to reach areas, that is in and around Goma, and not in the periphery where in fact the majority of the populations, the displaced populations and overall population were living. So, there we have, the potted précis of where we find principal holes and gaps. Why exactly does this come about? Well, there are many factors, and the work that Sandrine and I have done point out many factors, but I just point to two. The first thing is, I think it was very clear to us when we looked at these cases that the principal determinant of who gets humanitarian assistance is based on status rather than need or vulnerability. What I mean by that is whether a person is registered as a displaced person or a refugee with the UNHCR or whatever the government agency responsible for refugees or displaced people is, and the nature of the camp that they live in. So that was most noticeable in the Kivu situation, but it was also very noticeable in Jordan as well, where approximately 10% of the refugee caseload are unregistered, and where actually there's been, until very recently, HCR are trying now to do more, until very recently there's been very little effort to get towards those. So you really have a cascade that, the ones who get most of the assistance are those in official camps, and then unofficial camps, and then open settings, and then unregistered in open settings. And that was very noticeable in all of those three settings. The second issue is further to that, is that what we also noticed was that there was a very heavy lean in the assistance that was provided to what we might call easy programming. That is, that if populations were easy to get to, easy to identify, easy to target what their needs were, then the chance that they would get assistance was very much higher. Now, in a certain sense, that's logical, because of course easy things generally get done first, but our findings were that a significant amount of this can be put at the door of cultures that I think have developed in agencies whereby to address needs in a relevant fashion is significant enough. That you go beyond that towards getting to the hardest to reach people or the hardest to reach places becomes triaged, as we would say in MSF. It becomes put in a too hard basket. So to give you examples of what I mean by that, that is, as I mentioned, unregistered Syrian refugees in Jordan cities, or people in famille d'accueil in the periphery of North Kivu. These people, despite having major needs, get very little assistance. And why is that important? Well, I think that's important because if we're going to relate it to our discussion that we had earlier about access, if we want to talk the talk, then we need to walk the walk. To what extent do we actually practice impartiality, that is providing assistance on the basis of need and not any other criteria? Well, in the three cases that we examine in particular, we would say not very much. Rather, convenience, the capacity to get a contract which will justify presence and create work, managing risk, not only security risk, which was very significant in North Kivu, but also the risk of a program failure and having to report a program failure. We found that these were more significant influences of who got assisted and who didn't than a concept of who needed it and who didn't, who was vulnerable and who wasn't, or so forth. So, I mean, for us coming out of this, I would think that this is something for all agencies. We don't, by any stretch of the imagination, in fact, many of these things I think are just as relevant for MSF as they are for any other agency. In these three emergencies, I think there are many good things about MSF's own emergency response, but there are many points on which I point here which also apply to us. And for us, we're trying to say with this work, more needs to be done to focus on improving emergency response, improving coverage and emergency response in particular. Thank you very much.
Sean, thank you very much for that, and thank you for being so actually concise and clear. Just a quick question. It sounds like really fascinating research that you and Sandrine have been doing. When will that be published?
We have a plan to publish a network paper with the Humanitarian Policy Group. We've promised Wendy Fenton the draft by the end of November. So I'm presently now trying to get people's comments on it, in particular from my MSF colleagues, so that I don't get my throat cut when it appears. But the concept is February of next year it should be published.
Right, well, we'll look out for that. I think we had some good news from Sean, but we also had some, I think, very worrying news. I mean, the good news is that you found that you are reaching a lot of people. But for me, the most worrying news there is that the principle of proportionality in aid, that humanitarian aid should be delivered in proportion to humanitarian need, really is fundamentally at the heart of what we're all doing. And I think what Sean is telling us here is that that's not happening for two reasons. One is this thing about status, and it will be very interesting to see what this hierarchical status thing that you have when you publish the paper, what that consists of. But that's very worrying. And then sounds like is it a kind of laziness, easy programming? Sort of.
There's a laziness and there's a risk aversion there as well, I think.
Yes.
And I think that it connects to some of our previous discussions earlier in the morning about the way that humanitarian agencies view risk in the broadest sense and the way that they manage that.
Brilliant. Right. Next up, it's Frances. Over to you.
Thank you. I'm going to add one more thing. It's not just laziness and aversion to risk, but it's also hidden assumptions that humanitarians and development, actually, agencies as well, make, and which are implicit, they're not explicit, and that's why they're really dangerous, and we need to expose them so that we're aware of those assumptions are being made. So I wanted to start, as John did and as Eve did this morning, in fact, with the question of humanitarian principles, especially humanity and impartiality, which are the core, the heart of humanitarianism, which means that all people have equal value and dignity. And if an individual or a group of people is neglected or excluded on the grounds of race, nationality, religion, or politics, It would be completely contrary to humanitarian principles. And we in HelpAge International think that neglect on the grounds of age needs to be added to this list, because too often humanitarian responses are failing to meet the needs of older people. So I'd quite like to start with a question to you. How do you think your grandparents or your parents would fare in a humanitarian crisis? I sometimes wonder what would happen to my parents if they were caught up in an emergency. They're in their mid-80s. They're in pretty good shape for their age, but my mother has arthritis. She can't move around very easily, and she needs pain medication. And even with this, she's not able to walk long distances to, for instance, a health centre a kilometre away. And she certainly wouldn't be able to stand in queues for long hours or carry heavy packages or, for instance, water containers. My father has a heart condition, potentially life-threatening, but so long as he has his medications, he's okay. As they get older, they feel the cold much more than they used to, and they need their heating. Both of them have got failing eyesight and would be lost without their glasses. My father's also getting quite deaf and actually is less on the ball than he used to be. And these are all quite normal conditions for people in their 80s. And they would undoubtedly make my parents very vulnerable in a crisis, especially if they lost their home and they didn't have the support network of us, their family, their friends, their GP, the local hospital, and other public services. So none of this would change in a humanitarian crisis. So why are they so routinely overlooked in humanitarian responses? My parents have obvious support needs, but they themselves actually play an active and really valuable support role for the family. My brother and his wife and my sister and her husband completely depend on them for childcare so that they can go out and work. So my parents are old, but they're still the hub of our family, and this wouldn't change in a humanitarian crisis either. Now, luckily, my parents live in London, and it's very unlikely they will ever be caught up in a humanitarian crisis. And we all know that disasters are more likely to occur in poorer developing countries, and their humanitarian impact is much greater in those sorts of countries. Many people also think that population ageing is really only an issue for the developed world, that in developing countries there are very few older people, so they're not really an issue for development programs or for humanitarian action. But they're wrong. The number of older people in developing countries is growing faster than it is in developed countries. Today, 60% of the world's older people live in developing countries, and by 2050 it'll be more than 80%. And here's another unexpected statistic for you. Within the next 5 years, the number of people aged 65 and over will outnumber children under the age of 5. And by 2050, older people will outnumber all children under the age of 14. So this has very clear implications for the humanitarian system, a system that at the moment is focused very much on children and their mothers. Demographic change means that older people constitute a significant growing number of the people who are affected by humanitarian crises. Another common misconception is about the way societies treat older people. Again, many people think that in developing countries, traditional social and cultural values mean that older people are always cared for within their families and communities. Unfortunately, this assumption is also often wrong. Conflicts and disasters bring chaos, intense family pressure on resources, and often break down communities and social norms. And this means we cannot simply assume that older people are cared for by their families and communities. A couple of examples. After the 2010 floods in Pakistan, about 10% of the older population was living without any family support. And in the IDP camps in Darfur in 2004, 5, 6, half the older people were living alone. So let's get down to a few details. I'll give you 3 examples of how the humanitarian system is neglecting older people. First of all, in monitoring and surveillance. Effective humanitarian assistance relies on assessment and surveillance data. Almost all the guidance, the Sphere Handbook and all the other guidance requires the collection of sex and age disaggregated data. But in practice, data on all adult age groups is always aggregated. it doesn't take much expertise to know, in health, for instance, to know that the health needs of an 18-year-old are not the same as those of a 60-year-old or an 80-year-old. But the data on an 18-year-old is aggregated with the data on an 80-year-old. This leaves the profile and needs of older groups completely invisible. MSF did an exploratory analysis of data from the South Sudan refugee crisis, as Sean mentioned, and during a 6-week period, data were aggregated by age into various age groups, under 5s, 5 to 50, and over 50 years old. And the mortality rate in the oldest group was over 4 times that of the 5 to 50-year-old and twice that of the under 5s. And this was at a time when the crude mortality rate was just below the emergency threshold of 1 death per 10,000 per day. And similarly, the standard indicator of whether a nutrition intervention is needed in the population is the nutritional status of children under 5. No nutrition surveys are ever carried out amongst older adults. HelpAge International actually did probably the first one that's ever been done in the refugee camps of Dadaab a couple of years ago. And this found very clearly that older people are vulnerable to malnutrition, that they are not included in any nutritional surveys, and they're not included in supplementary or therapeutic nutrition programs. So the second area in which the humanitarian system is failing older people is in terms of guidelines and expertise for chronic and communicable diseases. Older people, as I've just mentioned and as we all know, have specific health needs and risks. And global aging is recognised as a major driver of non-communicable disease in developing countries, where older people are especially high risk of things like cardiovascular disease, strokes, diabetes, and dementia. But non-communicable chronic disease is neglected in humanitarian responses. There are virtually no guidelines for the management of chronic medical conditions after disasters. The latest revision of the Sphere Handbook does recognise the increasing evidence of acute complications from chronic diseases in disasters, and it says they should be treated, but very, very few agencies are actually doing it. Older people can also be at increased risk from communicable diseases. Infectious diseases have a specific presentation in older people. This is most obvious with respect to HIV and TB, but also applies to infections such as diarrhea and pneumonia. And there are reports of higher parasite loads and higher proportions of severe forms and an increase in fatal disease associated with malaria amongst older people. Again, another study that HelpAge did together with MSF, the preliminary results of a study of the cholera treatment centres in Haiti indicate that people over 60 years old are much more likely to present with severe hydration as opposed to mild hydration when compared with younger adults. After controlling for other factors, people aged 80 years or 80 years or over have 11 times the mortality of younger adults in cholera treatment centres. But older people are rarely identified as a high-risk group for communicable diseases, and their specific needs are very, very rarely considered by infection control programmes. MSF recently did an internal review of its programmes, and it highlighted a lack of specific organisational policies on meeting the needs of older people, even though they are usually viewed as a vulnerable group. MSF's response to their needs was very variable, and it's now translating these research findings into operational policy and practice. And quickly, the last area that I want to highlight in which older people's needs are being neglected is in terms of funding. Institutional donors don't treat humanitarian assistance for older people as a priority. HelpAge International has done a series of studies where we've analysed the projects that were funded through the UN Consolidated Appeals Process, the CAP. And this shows that while 11.5% of the world's population is aged 60 or more, 0.3% of projects submitted to the CAPs included any activity that specifically targeted the needs of older people. In 21 countries, there were no projects at all targeting older people in the past 2 years. So what do we think needs to change? As the numbers of older people affected by humanitarian crises and disasters increase, humanitarian actors need to adapt policy and practice to ensure that the needs of older people are properly considered and that this vulnerable group is no longer neglected. We've identified several priority areas for action and research for humanitarian agencies, researchers and donors. In practice and policy, humanitarians need to start collecting age disaggregated data on who is accessing humanitarian assistance to ensure that older people are not excluded. We need to make sure that all surveillance and needs and vulnerability assessment data is disaggregated for older age groups. We need to systematically screen older people in nutrition surveys using MUAC. We need to provide adequate care in emergencies for chronic diseases and conditions, including palliative care and pain relief. We need to ensure livelihoods and food security programs are available to older people and accessible to them. And we need to ensure that the specific protection needs of older people are understood and addressed. In research, we need to do more operational research on the best ways to ensure that older people are included and the type of aid that they need, the assistance they need. And in funding, institutional donors need to get over their prejudice and they need to start funding projects that include activities addressing older people. But the most important thing that you can do next time that you're involved in a humanitarian response is to ask yourself, how would your parents or your grandparents fare? And how could you make it more easy for other people's parents and grandparents to survive that humanitarian crisis?
Frances, thank you very much for a very vivid explanation of this particular problem and some analysis of why it's taking place and some suggestions for doing something about it. I mean, I think many of us will find it surprising that agencies routinely overlook old people, and it will be interesting to hear from any nutritionists in the room, if there are any, why in anthropometric data and nutritional surveys this is the case, and medical people, why you're overlooking elderly people when it comes to guidelines for communicable diseases. And
non-communicable diseases as well.
Right. So what we have from Sean, just in very sum, we've got a little bit of good news from Sean, but some worrying news. I think we can only say we've got worrying news from you, but things need to change, don't they? Good. Corinna, please, over to you.
Thank you. I will talk about coordination and coherence. The State of the Humanitarian System Report 2012 has already been mentioned, and the survey that was done amongst humanitarian actors revealed that a poorly coordinated response was cited as the main hindrance to effectiveness, and that it is seen as the biggest weakness of the overall system. So logically, we need to improve coordination. Well, this has been on the agenda for quite a while. You mentioned the humanitarian reform that came in 2005, so the big question was, how do we do it? And in order to do it, we created a very sophisticated system. And this morning, Yves Dacot was asked sort of, what good advice do you have for people who want to become an aid worker? One piece of advice from my side would be, you have to be up to learn a lot of abbreviations and acronyms. So I'll test with you a little bit how far you have come and how good you're prepared to enter the jungle of humanitarian coordination. So I'll show you a series of acronyms, and I would like you to, hand on your heart, do I know this or don't? There are 10 altogether, and we'll see how many points you can collect. The first is ICWA. CHF, just count by yourself. HCT, CAP, GPC, SURF, IASC, HCRC DSRSG, that's actually a person, a function. We have OCHA, and we have the GHD. So, who thinks you know 8 out of those 10? Please lift your hand. Oh, okay. 9? Somebody who knows all 10 of them? Okay, we'll go briefly through them. ICVA is the International Council of Voluntary Agencies, a consortium of NGOs based in Geneva. GPC is the Global Protection Cluster. We'll get back to that word. CAP is the Common Appeal Process. CHF is Common Humanitarian Fund. IASC is the Interagency Standing Committee. HCT is the Humanitarian Country Team. SURF is the Central Emergency Response Fund. The GHD is the Global Humanitarian Donorship. And then this complicated person is at the same time the humanitarian coordinator, the resident coordinator, and the deputy special representative of the Secretary General. And finally, OCHA is the Office for the Coordination of Humanitarian Affairs. So the big question is, has all of this improved coordination? The expectations we had towards the system was to ensure better predictability, to allow for a more effective response, being accountable and responsible to the people, and finally to have a more harmonized collective approach and work in partnership. What we see so far is, yes, to some degree there is a better predictability. And I would like to take the example of pooled funding, SURF being one, the common humanitarian funds at country level, where several donors put their money together and establish structures in the country to allocate that funds. And I think that's significantly better than 2 people sitting in Tokyo, 3 in Helsinki, maybe 4 in Berlin, and a lonely person somewhere else in the world trying to figure out what's the best for the people in Goma. It's significantly better if they pool their resources and make joint decisions. It's also better if we meet more often and have information more readily available. And it can be useful to know who is responsible for what in the system, because then we know whom to blame, and we like to do that, at least behind closed doors. However, with regards to the more effective response, we have seen that especially the cluster system led to very lengthy processes and often has become a mean in itself, an end in itself, sorry. And finally, with regards to the more harmonized collective approach, we see actually a situation where we have insiders and outsiders. The insiders are those who come to the cluster meetings and who play by the rules set up by that system. The outsiders are partly organizations who decide themselves to stand on the sidelines. ICRC and MSF would be the 2 most important examples, declaring themselves often as observers. But that leads to the fact that in the health cluster, for example, the biggest health agencies aren't really in the room. And we have outsiders that have not chosen to be outsiders, but they are actually left outside. That's mainly national NGOs. That's government to the extent that they are relevant. And it's also what we call the emerging actors. Arab donors, for example, Muslim charities who don't accept that the rules we have set up over the last 15 years are the ones that they should follow. So what should we do? I think needs must be the overall focus and the measuring stick again. As Sean already mentioned, we need to know how good are we in covering needs, and then we have to fill them and not sit in more rooms for longer periods of time to discussing them. We have to put the rules up for discussion. If there are new kids on the block, we have to actually debate what are the rules of the game, and we cannot continue pretending that just because we did this type of business for the last 20 years in this fashion, we will continue to be the ones who dictate to the others how they have to play. And finally, we have to come to action instead of lip service. We have to fill the gaps and don't discuss for ages where exactly they are. Thank you.
Corinna, thank you very, very much for that. I think it's wonderful to see so many young people here, and I'm glad that you're getting so much advice about how to get on the career ladder. I mean, I think Eve this morning gave you some really wonderful, clear advice, which I think you should all take. And the idea of learning acronyms is also quite clever. I know in my day, all we had to do, we didn't really have to do anything except hang around in an agency and, you know, walk up and down the corridor and then, you know, sooner or later you'd end up in Sudan or Ethiopia, but thankfully it's not like that. As Eve said this morning, the system has become more professional, and that's very good. I think we had a little bit of good news from you, in as much as the clusters has made things a little bit more predictable, which is good, but you are seeing a more fragmented kind of response because of the clusters. Is that correct?
Yes, of sort of people considering themselves as the right players if they are members of the clusters and play by the rules, and look a little bit down to the others who don't consider the cluster the center of the humanitarian world.
So even in this we have winners and losers. Good. All right. Well, we have 36 minutes. So it would be great to open the floor for any questions, points, anything you'd like to say. I can see. When I come to you, would you be good enough to say who you are and who you work for, or what you're studying, or if you're doing anything else? It would be interesting to hear. And I hope we have some help with the microphone. I can see some people, so I'm going to take the gentleman up there with a hand up, and the lady right in front of me. Did you want to ask something? Or you did? Yes. Okay, that's very good. And right up on the left there, you can be third. Is there a fourth one anywhere? Yeah, there's two up there. Well, we'll take five. We'll take you two after the lady on the left there. So we've got 5 questions, or 5 points. Please.
Thank you. So I'm Caroline Aboussada from MSF. One question, it's a comment on Karina's point, and it's a question to Sean. Is it, and I'm talking only about emergencies, is it really that we're lacking coordination among actors during emergencies, or is there a lack of actors during emergencies? Just one quick example on Dumi's camp in northern Iraq. UNHCR was coordinating the response. The water sector was delegated to an NGO, and the NGO was not there to actually really respond to the need. And there was no accountability to the delegation that UNHCR had done. So here's my point. I mean, it's a question on, is it that we are lacking coordination, or is it that there are no actors willing to respond in emergency, or at least in acute emergencies? Thank you.
Thank you very much. We'll take the gentleman right at the back, please. Sir.
My name is Adrio Bacchetta, formerly of MSF, now working as a consultant. Now, my question is to you, Sean, about what other research is out there, whether some of this has been a part of your research. But has there been work done looking at the strategies of the different organizations that are involved in humanitarian aid to see where humanitarian aid fits within their mission, alongside anti-poverty, alongside human rights, so that you can see what level of expectation may come in terms of the response that they may give? And then the other element there is also looking at how is this varied over time? So not just looking at a single intervention, but are there variables over time where you can say, this is how things have changed, and also putting alongside that donor policies, how much of these changes are donor-driven. There's been a lot of investment in accountability to beneficiaries over the past years. What's that doing in terms of generating response, and so on and so forth? But are you aware of any research, or is that a part of your research, looking at those sorts of variables?
Thank you very much. We'll go right over to the left wing, the blonde lady in the corner, please.
Thank you. My name is Frauke. I'm from MSF. Question for all of you. The concerning point of exclusion by status, isn't that implicit in the system and the mandate of UNHCR? Only treating, servicing those people who have a specific status? And what's the solution in situations where governments usually are unable to address the needs anyway on the ground? So the actors who are there have the mandate to treat the refugees only with specific status, which is in almost all displacement contexts the case.
Yes, thank you for that one. You'll have to put your thinking caps on there, won't you? That's a tricky one. We have two people at the back, I believe. Yes. Adam, please, when the mic comes. You can speak without a mic. Okay, well, that will be... you don't have to, it's okay.
It's here, Well, I'm Dalia Novak from Germany. I'm a neurologist, and I was asking about dementia and vascular, like strokes, events which are happening more often, especially in developing countries where life status is growing, getting better, and we are still facing problems in Europe so far. How we do how do we do the management of older people? What steps have been made so far in other countries, like in Africa, where, for example, stroke and dementia are, people who suffer from it, who are like a group apart, who are not really considered as a really point of interest so far. What steps have been made? What co-workers do we have, like those human organizations? Do we work a lot with the WHO, or are there other possibilities to make some more pop in our fields in Europe to underline this problem within, let's say, within a world where we get more and more old people?
Thank you very much. Well, I think Francis will take that one in a minute. And finally, number 5, please.
Thanks, Elke Aderholt, German Federal Foreign Office. I would like to focus on coordination and thank Corinna for her encouraging remarks, because also from a donor's perspective, coordination indeed is very, very important. It would not be very useful if we in Berlin would take one decision, in Paris somebody another decision, and in Tokyo yet another decision. For us, it's very important as donors to take decisions collectively, to build on coordinated needs assessment, etc., etc. We agree that it's very important to avoid lengthy processes to make the system less burdensome in all regards, also, for example, not only in terms of coordination, also regarding, for example, accountability. Regarding insiders, outsiders, we have not really a problem with ICSC and MSF being outsiders, because this is very important and very helpful in a certain set of crises. We are very worried about outsiders in outsider governments, governments who not subscribe to humanitarian principles, new donors. So one focus we have regarding coordination, to bring in emerging partners and to make them subscribe to the humanitarian principles.
Thank you very much for that. It's really useful and important to get the views and perspectives of the Foreign Ministry, so thank you very much for that. Now, we have 2 questions specifically for Sean, around one on coordination and one about research programs. We have a question, that difficult question in the corner there about triage for all of us, and one particularly, I think, to Francis, about the management of elderly people. Should we start with you, Sean? Is that all right?
Sure. Adria, your question first. Some of the specific questions you raise did present in the case studies that we looked at. Some not so much. For example, the drive for accountability to beneficiaries, which John, you've been very involved in, indeterminate in these cases. Our focus wasn't on donor demands, but there's no question. Well, there seemed to be the case that donor demands on agencies working in the field have had important implications for how rapid they can respond and how effective they are. Although I should point out, and in many cases it was negative, but I should also point out that there were a number of cases that we came across which were more positive, actually. So we shouldn't necessarily beat up on the donors that, well, I don't want to draw a conclusion. One of my principal conclusions is actually about agency practice rather than, our donors are telling us that we have to do this or that or so There were agencies which had negotiated pre-agreements with their donors which would allow them to get credit, lines of credit extremely quickly in the case of emergencies that were needed, and that allowed them to mount very significant emergency responses in some cases. So, you know, there's good and there's bad. And as for the strategies of agencies, including multi-mandates or so on, it didn't seem to be a principal determinant that we saw of performance in emergencies. So one particular agency that I'm thinking of, multi-mandate, performed badly in one particular emergency by their own admission, but actually rather well in two others, right? So, I mean, one of the conclusions that I draw from that is that a lot actually comes down to culture and practice, but also management and leadership at country level, because I would attribute the distinction in one place. This is this old issue of, a long-standing issue of shifting gears from long-term to emergency programming that I think all humanitarian agencies, including MSF, can suffer from. But a lot of that comes down to strong national level leadership, country level leadership. So that's what I'd say in that. So a little from column A, a little from column B in terms of what we see on that. The other question was from you, Carolyn. And here it touches on some of the things which are in the work that we saw, but I simply didn't have time to look at here. We did try to look at the presence of external constraints on presence, because clearly there were some. Security and logistical constraints were present, particularly in the Maban case for logistics, for the North Kivu case for security. They were clearly there. But also the other one, which very evidently had an influence, was the visibility of the particular crisis within the international community. So there was very large presence by very many organisations in Jordan. For an obvious reason, Syria is the crise du jour, and also Jordan is the most accessible component of the refugee crisis. Many can't get into, including MSF isn't also happy about what we can do within the country, so you shift to the refugee areas, and Jordan is fairly easy to do that, and then Zatri, the major camp, is even easier than that. So, and very visible. I mean, in the week that we were there, you know, they have VIP schedules at this camp, right? They have, every day they have a foreign minister or someone visiting. And then Maban was a proof of that in the negative. One of the reasons why we assessed that there weren't so many agencies there was because actually it was somewhat of a forgotten crisis. And then if we look at others, like your Domiz camp in Iraqi Kurdistan, or CAR, as Tom Roth was talking about in the previous session, that's clearly a factor as well. So it can be poor coordination. Coordination wasn't wonderful in North Kivu. It wasn't disastrous. It wasn't wonderful, though. It did slow things down, and the very things that Corinna mentioned we did see there. But in other cases, it was lack of actors or lack of sufficient actors capable of functioning. So I think there are a few factors that lead to that, what do you call it, you know, famine or flood situation.
Yeah, just to add on this, I think we have enough or too many of the convenient, or the actors going for the convenient programs, and we don't have enough of the actors going for the really difficult to reach populations for different reasons. I would like to try to touch on the question of the exclusion by status. It's a minefield to get into the debate on the mandates, especially of UNHCR versus and with the sort of mantra that refugees can't be clusterized, and the situation that we then find in a situation of mixed caseloads where we have IDPs and refugees both living in similar dire conditions. Where I would personally sort of draw the red line is an example I've seen in DRC, where the arrival of 300 refugees from Central African Republic in a very remote place sort of draw their attention and sort of a huge amount of aid versus, while at the same time 30,000 internally displaced people in the Kivus didn't get any attention at all. And that's where I think sort of this becomes unacceptable from an impartiality and humanity point of view. But obviously there are debates sort of how far we want to go into questioning there is a certain level of protection that is enshrined in the Geneva Convention. So we want not to completely damage that special coverage for people. At the same time as we need to make progress on balancing status with vulnerability. In DRC, again, clearly there is a huge consensus amongst 95% of the agencies, I would say, that we target according to vulnerability and not status. And that led to also, for example, that influenced the decisions of allocation of pooled funding. And I think that was a very consequent and welcome development. But it is a huge debate, and with the Syrian crisis producing so many refugees, again, it comes up as a more urgent question than ever before. On the insiders, outsiders, the problem I have with MSF and ICRC, for example, not being part of the health cluster is that any data that the health cluster produces on the coverage of the response is totally biased and does not reflect the reality. And the WHO budget is often a fraction of the local MSF budget, and still they are claiming that they call the shots on the coordination. And I think that's just a very unrealistic picture of what's really out there, and therefore the fact that the most important actor is not part of the system is particularly a problem in the health sector.
Thank you very much, Corinna. Francis, would you like to address the question about the management of elderly people?
I would. Could I actually start by just picking up on what was said very briefly?
Absolutely can, yes, of course.
Thank you. Sean, I think you let the donors off too lightly. And I think, you know, in MSF you're slightly kind of insulated by the luxury of having so much private funding. But for the reality, for those of us who work for agencies that are largely donor dependent, the reality is that we depend on donors and pooled funds that take months and months and months to act, to get funding through the system. So, for instance, at the moment, we and many other agencies are trying to work in the Syria crisis, and it's taking on average 9 months between concept note and proposal approval stage for us to get funding. I mean, we're completely hamstrung. And if you depend on the pool funds, UN-managed pool funds, by the time it trickles through and gets to the NGOs through the UN system, it's 12 weeks on average for the SURF, and it's 3 or 4 months on average for the ERF or CHF. I mean, it's not possible to operate like that, and for that reason, there's a bunch of British agencies got together, and we're creating a thing called the START Fund, which is in fact going to be an NGO pooled fund, into which donors will contribute, and they are already starting to contribute. And it'll be managed by NGOs for NGOs. It'll get money out of the door within 48 hours. We've piloted it and it works. And this, I think, stands a chance of transforming the way NGOs that don't have the luxury of a lot of private funding will be able to respond much faster in disasters. Fingers crossed. Anyway, so that's the START Fund. That's a name check for you. Watch it. Go on to the CBHA website. It used to be called the Consortium of British Humanitarian Agencies. And we just changed the name to the START Network, which is a bit more easy to remember. And but the website hasn't changed. So if you look at yes, it's another one you didn't have up there, another acronym you didn't have up there. But anyway, the START Network. If you go to thecbha.org, you can find out about it. Anyway, to go back to older people and treatment for dementia and for strokes, but I'd add to that heart disease, diabetes, rheumatism, arthritis. I mean, these are all conditions which are very, very common for older people. Cataracts, eyesight, failing hearing. And Yeah, I mean, in general, if you look at the state of the art of healthcare for older people in developing countries, it's not great. A couple of examples I'll give you, and my examples come from the humanitarian side. I'm not familiar with the kind of overall picture in terms of health system development, but. When we went to set up a program in North Kivu a few years ago, we've got a wonderful Congolese gynecologist working with us, works with the Ministry of Health. He's the only one for the whole of Eastern DRC. And in Haiti, it was a similar thing when we set up our program after the earthquake. Well, it wasn't similar actually; it was totally different because there are no gynecologists. So did I say gynecologist? I meant gerontologist, sorry. There are no gerontologists in Haiti. I met somebody from WHO when I first went there, and I said, could you tell me who are the best people we should be speaking to? He said, there are none. He'd been working there for 7 years, he knew. So, it's thin on the ground, but the point that I was making is actually, regardless of what the general situation is in the ministries of health in developing countries, when humanitarian agencies go in, they're the same. They don't respond to older people's needs, even though they come from places like Germany or the UK, where we do prioritise older people's health needs. So why does it get filtered out? I just don't understand it. Why do people filter out older people? We know that they're there, we know that they need help, but somehow we always turn to the children.
And sorry, just one quick thing for Frauke's question about status. Corinna touched principally on some of the legal things, but the other thing, there is a very significant set of constraints involved in actually getting into the system. You have to get registered, you have to be assessed as being registerable, and that is not always as easy a process as it sounds like it. Sometimes it's administrative difficulties like backlogs. There was a very significant backlog in Jordan, although HCR have now managed to reduce it, more or less eliminate it, which is fantastic. But also, not only that, there's in North Kivu, one of the principal issues is fear of fraud. So there are enormous and laborious systems in place to try to prevent false registrations, and very complicated contract structures in order to do that. And in one particular case that we found in the town of Kichanga, it meant that displaced population displaced in December didn't get any assistance of any kind from HCR until April. So that's what, 5 months. So yeah, I mean, there's some other barriers as well that I think are probably under-recognised and that should be foregrounded. Not to underplay the legal issues, because there are very significant ones, but there are also some organisational and administrative ones which are perhaps under-recognised.
Thank you, Sean. Just before we move on, just for a second, I just want to double-check something to make sure that I heard you correctly, Francis. It takes 9 months from the putting in a concept note for funding for a rapid response emergency to get the funds. 9 months. Yeah. Did I hear that correctly?
Yeah. That's DFID and ECHO. It's both that at the moment. It's not. You could say, oh, HelpAge doesn't know how to do grant management. It's not just HelpAge. It's many other agencies who very, very experienced agencies who are having exactly the same problem.
In North Kivu, where the Pole Fund was, of course, one of the pilots for it, it's 3 months concept note to actual action. So they have had to set up effectively a substitute funding system in order to get the first week 0 to week 12 covered. Called the RRMP, working not that bad. And actually NRC is involved in it and not doing too bad. One of the things that I was talking about, but for me, a rather large admission of failure that you actually have to do that.
Yeah, absolutely.
I would disagree with that, because Congo, I mean, we have had now an emergency every week in Congo ever since 1994. And I think the RRMP, Rapid Response to the Movement of Population, is a system that that prepared the humanitarian community to anticipate the fact that there will be a new displacement crisis in somewhere in the Kivus next week. I don't think it was a reaction to the funding mechanisms being too slow, but it was really us knowing that there will be continuous local displacements, and therefore we need this rapid response mechanism. And I would like to put back on, I've worked for ECHO for 6 years, so I still feel sort of also the need to defend the donor occasionally. Because we continuously had this criticism, it takes so long, I made statistics myself, how many days it took us to respond to corrections or to a first draft of a proposal, versus how many days it then took the partner organization to send us a revised version. And frankly, it wasn't that black and white where the failure was. So just to also defend a little bit the donor side.
Corinna and Francis, you two can meet later over a coffee and find a nice position there. So let's take a few more questions. Okay, I'm going to take that gentleman there first, and then a gentleman with the blue shirt, and I'll take the lady there with her hand raised, thank you, and the gentleman sitting on the stairs at the top. Oh, yes, hello. Okay, let's go with those four. Sir, please, you first.
Thank you. My name is Tamam Al-Awdat and I work for MSF. Corinne, you mentioned that the session is titled "It Isn't Working," and then you mentioned that it's somewhat working on some of the assumptions. One question would be, do we know that the changes that has happened in the humanitarian system after 2005 have actually participated in better survival, longer life, less diseases, less mortality, or any of that in the people that this system actually aims to serve? And if the answer is no, or given the massive cost, I assume, implied by creating a UN agency to coordinate other UN agencies and organizations, if that isn't working, what's the solution? No one is saying what would be the alternative, or would we just continue with the half-functioning machine?
Thank you for that. Sir, please.
Thank you very much. My name is Tim Pitt. Between 1992 and 2005, I worked for MSF primarily as a head of office, or head of mission. And from 2006 to 2011, I was primarily a head of office at a country level for UN OCHA. So I look at some of these issues from both sides of the table quite literally. I'd like to ask Sean and Corinna in particular about money. And I don't mean how to get it, but I mean its effect, its inference within the organizations and what happens. I think in particular about Kosovo in 99-2000. We had 450 NGOs, more than that. We had every UN agency you could ever imagine, and also 15 NATO countries that were all doing aid projects of one sort or another. It wasn't even an emergency by morbidity and mortality standards. And Kosovo was only 180 kilometers by 160 kilometers. It was too much. You had in Uganda on occasion well-financed NGOs like MSF that continued programming and doing things, although the context, I would argue, did not fit that. And yet we have, certainly in Haiti and in Afghanistan, very politicized money coming from governments. In Iraq, in the middle of the 2000s, if you took American money, you were an implementing partner of an occupying power. So when we talk about the coordination and reaching people and doing needs-based programming, I have some questions about how money impacts things, and I'd like to know what you think of that. I'll leave you with two thoughts, if I may. The first is that from my OCHA experience, I can tell you the most dangerous poison to coordination is a well-financed organization absolutely convinced that they need to act immediately, irrespective of either information to confirm or information to deny the value of their program. The second thing I'll say is that coordination in emergencies is a little bit like communication in a marriage. It's always an issue.
And on that note, we'll move on to the lady up there. Thank you. Thank you, sir.
Thanks. Is this working? Yes. I'm Sophia Swith, and I'm from the Global Humanitarian Assistance Programme. And I keep looking at Corinna's top line there of her slide, needs must be the overall focus and measuring stick again, which I couldn't agree more with. But I find very often in these discussions there's an assumption that needs and vulnerabilities are objectively known facts, and that all humanitarians have to do is go out and impartially meet those needs. But in fact, as Francis's presentation has pointed out, and as criticism of the CAP has also highlighted, needs assessments often just reflect the geographic presence, the access, the specialisms, the capacity of the agencies who will then go out and meet them. So my question to all of you, particularly to Sean in the light of his work as well, and to Corinna, is how can the needs assessment part of the system be improved so that itself is no longer a gap? Thank you.
Thank you very much. And now, finally, we'll go to the top of the stairs. Thank you.
Hi, my name is Luca. I work for Transparency International. My question is to Sean. You mentioned anti-fraud policies as a reason for delay, or you mentioned anti-fraud policies as a reason for delay in registration processes. So I was wondering if actual corruption within organizations is also a reason for this, or acting as an obstacle to accessing populations. And because I was baffled by this distinction between easy to access and remote populations. So corruption within that sort of distinction. Thanks.
I'm going to squeeze one more question in, sir. Thank you.
My name is Ehsanullah, and I am from Pakistan. I work with an organization named as BEST, a national NGO, Basic Education and Employable Skill Training. We are implementing partner of about 6 UN agencies and GIZ. My question, it is a question, and also I want to share with you that as far as the cluster system is concerned in humanitarian response, as far as my experience is concerned, in 2008 flood, 2010, and now in IDP's response. Although cluster has increased coordination and response, but as far as my experience is concerned, it has also decreased, it has also delayed the response to needs. Because when a cluster responds to an emergency, it hinders emergency response because the people in need require very rapid response. But due to higher hierarchy and more members of a cluster, the response is delayed. And due to this delayed response, very important lives are lost. Because I have practically and I have personally worked in 2008 flood, 2010 flood, and now in IDPs. Because whenever we submit a proposal regarding, as far as you have mentioned, rapid response or rapid fund, the response from the donors normally delays so much that when they fund us, the need for that specific project does not exist anymore then.
Thank you very much. Well, that's an interesting question in the light of the gentleman's question over here, or not question really, point, which was about the dangerous poison, which is about acting too quickly. So there's it's the money. Okay. Well, I'll hand both of those ideas over to the panel. Please, Corinna, perhaps?
Yeah, the first question was sort of, do we really know whether the cluster system helped to save lives or not? I have two sort of issues with proving that. Well, first is the attribution problem. Even if we saved more lives, was it due to better coordination or for other reasons? And the second is the counterfactual. We can't sort of say what would have happened if we had not had the clusters. I started working in humanitarian before the cluster system, and I see sort of the point. It helps to know who is normally responsible for example, water and sanitation. So at least you know whom to talk to and where you can sort of hold people accountable. So I can't really answer the question. I think we would be worse if we didn't have good coordination, but definitely this is not the best coordination system that is thinkable. if I can answer that way. On the money, I think what we need is principal donors to actually avoid that situation that you described, a very well-funded agency that sort of drives out and does whatever they think or they had as a good idea that morning. So a lack of money can actually be, to a certain degree, healthy for the system because it forces us to make priorities jointly and also to sort of at least discuss what needs assessment methodologies we have. I could take the opportunity to promote a project that actually HelpAge and NRC and Merlin together have. It's called the Assessment Capacity, ACAPS. That is a standby capacity that is available to the system to improve joint needs assessments. But there's also a question sort of, is it the job of a consortia of 3 NGOs to do better needs assessment for the system, or shouldn't that be a common task? Yeah.
It's another one to add to your list, isn't it? ACAPS. Good. Sure? Francis?
No, I was going to mention ACAPS as well.
You were going to mention ACAPS, okay. ACAPS is mentioned. Sean, it's you, I think.
So, Tim's question about the impact of the money. Well, there are a couple of interesting things in Zatri, in Jordan. I think that what I'm not sure if I'm answering your question, but I'm just going to tell you what I thought when I heard your question. It might not be the same thing, but what is the impact of the money? One is, I think that there's a certain tendency for, maybe this is a humanitarian version of Say's law, you know, supply creates its own demand, right? Because in Zatri, what we saw, so this is the camp of 150,000 Syrian refugees in Jordan. This is actually, by objective standards, a very good camp. Most of the population are in trailers, you know, the kind of ones that you would see on a building site in the UK or in Germany, supplied by the Kuwaiti and Saudi governments. There is a lot of discussion jokes in the cafeteria about whether this is a 4-star, a 3-star or a 5-star camp. Most of the consensus was it's 4-star and that the UAE Red Crescent's camp is a 5-star camp, which is down the road. But there was a fairly large amount of gold plating is what I mean. Even discussions about whether the water supply should be refrigerated. And I think that there is, particularly in the more middle income settings, there is no question that the expense and the cost of these kind of things run completely out of control. And I don't doubt that one of the factors in Jordan why there was more coverage for the camp settings than for the city settings was that it was more obvious where money could be spent in the camp settings, and so it was, and then it was again, and then it was again, and then more holes were spotted. Education isn't great in Zatri, so then more schools were built in Zatri, and so on. And I think that there's an interaction between visibility and money, which I think comes in to play there. Again, don't know if it answers your question, but it's what I thought about. The question about corruption. So a lot of the focus has been principally on possibility of fraudulent registration by beneficiaries. And actually, I had the overwhelming sense of every discussion we've ever had in Australia about welfare eligibility when I was in North Kivu, which kind of terrifies me actually, because humanitarians as a welfare system is something we've talked about for a long time, but it's never quite punched me in the face so much. But there's no question that corruption within agencies is also an issue, and it also is one of the issues why the contracting requirements are so tight. And if I was sitting in a donor, I would understand why they would make requirements for contractual reporting that do that. But there's no question that it added to the delay of everything. And then this allows me to link that to our colleague from Pakistan. I was sitting in a camp in Kashuga, if people, some of the Congolese hands know where that is, up country in Kivu, and talking to a président de camp, and he said something along the lines of, you know, it used to be so easy when we displaced. I'll give the names of the agencies because he was very specific. He said Solidarité used to come within 2 days and then we'd have the things that we needed. But now, first the Comité National des Réfugiés has to come, and then PU has to come a few days later, and then a report is sent, and then UNOPS has to come, and then UNHCR has to come, and then eventually we might get something. And you guys are now so hierarchical and so bureaucratic that we really feel the difference. And the thing that I found interesting not only was the obvious message, but was the secondary message, in that they understand our systems because they feel our systems, they know who we are, they know what the names of the agencies are, and they can feel the procedures that are put in place, and that we shouldn't presume that there is a dialogue which is ongoing there, and we are telling these populations certain things by acting in certain ways. And I think that is a fairly decent ending point for me, actually.
Sean, I think you've just had the last word. The objective is for this. One of the objectives for this session was to get back on time. I see it's 4:30. We said we'd finish at 4:30, so we will. I'd like to thank you all for your questions, but most of all, could you give a round of applause to the panel for really very good presentations, and I thought really insightful and confident way in which they addressed the questions that you asked them. Thank you.